Welcome to Endo Battery, where we are sharing our endometriosis journey and learning along the way. This podcast is in no way meant to diagnose or give medical advice, but a place where you can gain knowledge and information that can help you to not feel alone as well as become your best advocate. We want to learn with you and support you wherever you are in your journey.
Thanks for joining us. I'm Shelby.
And I'm Alana, and we're Endo Battery.
Charging our life when endo drains us.
Thank you, Nancy, so much for joining us today. And for those who don't know who Nancy is like the pioneer woman of advocacy and excision surgery. And you are a lifesaver to many. And I know that you want to be humble about this. I see it in your face that you want to be humble and say no, but you are. And I have a gal sitting across from us. Her name is Chelsea. We just recorded with her, and you saved her life. And
wow.
She would have never known what to do with endometriosis or how to advocate for herself had it not been for you posting Nancy's Nook. And so when I say that you are, I think of you as like the mother of advocacy of endometriosis and excision, and that it is such a huge honor for us to have you with us today. So thank you so much for joining us.
Well, thank you. Thank you. I'm always happy to help however I can.
Oh, Shelby's already crying over here.
That's all right, honey. I've been in tears a few times myself, and I've told the story many times. I was never able to have children of my own, but through helping people who were able to do that, I now have babies all around the world. My oldest babies are in Toronto, and they're 30 years old.
Wow. That's so cool.
Yeah.
Chelsea's over here crying too.
Yeah. It's a tough disease to have, and it's very hard on us emotionally and physically, and there's a great deal of risk in it, and it has not gotten the respect it needs.
Yeah. Can you?
So I'm happy we were able to help you, Shelby.
Yes. Thank you.
All of us. Yeah. All of us. Can you tell us about your story, Nancy, so that we have a good.
Yeah. I had my first hospitalization at age 10 for acute abdominal pain. I had not started menstruating yet. And they took me to surgery to do an emergency apnea, and my appendix looked okay, so they left it. And they decided that it might be a cyst. They weren't sure. This was 1949 or something like that.
They really didn't have the tools.
Anyway. Yeah, right. So intermittently over the next 17 years, I had one ruptured cyst after another, and finally was hospitalized, and for the first time saw a gynecologist who said, "You have endometriosis."
Wow.
They tried some birth control. Said that didn't work. Said the only thing to do is we can cure this with a hysterectomy. We'll take your ovaries while we're in there. And so when that didn't help the pain that I was having, they decided I needed to have a back surgery 6 weeks later. Wow. So I had that done, and that didn't help either. Nope. So I spent the next 22 years dragging around a white, hot, painful left leg. Was constant. I slept no more than 2 hours a night, and it was just in 20-minute parcels.
Wow.
And sometime just before that, maybe about 19 years into it or 20 years into it, I was working as a hospital supervisor at St. Charles in Bend, Oregon. And I got a call from the operating room that said, help, we're on a case. We've been on the case for about 3 hours. We're not going to get out of here for another 3 or 4. And none of us have eaten. Well, hospital supervisors in those days did everything. So I trucked off to the kitchen, loaded up a dinner tray, put it on the dumbwaiter. And I was having so much leg pain, I decided to grab a quick cup of coffee and sit down in the back of the cafeteria. Unbeknownst to me, and now I suddenly realized there was this young gynecologist presenting to a small health forum of women with endometriosis his current research. And I thought to myself, gee, that's interesting. I had that once. And before, I didn't get to hear the whole lecture. I got called away to the emergency room to back up something. And so I was kind of thinking about this guy's work. I'm going, that would prevent some hysterectomies if he's right, Mm-hmm. It took me a whole year to figure it out. And I bumped into him in OB one night. This is Dr. David Redwine I'm talking about. I bumped into him in OB one night, and I said, hey, how's your research coming along? Oh, he said, it's really great. It just got accepted for publication in 3 different journals. And I said, wow, I'm the chair of the hospital's research and development committee. Would you mind presenting your work to them? I don't know what we're going to do with it, but I'd like them to hear what you've done. So he did that.
Mm-hmm.
And they were impressed, as I were, that it might mean fewer hysterectomies. And we were a Catholic hospital, so that was kind of an important piece.
Right.
Mm-hmm.
So I asked him if he would present it to the administration, and he said, well, okay, yeah, what do you have in mind? I said, I don't know. I don't really know. So he did, and after he left, the administrator said, so what do you want me to do with that? And I said, well, I want you to give me some money. I want to travel and begin to teach patients in the US and Canada. There were support groups all around the US and Canada at that time, really quite a few of them. So I spent the next 12 years virtually on the road, about 25 weeks a year, lecturing to these different groups. And about 3 years into this 12-year period, I was lecturing, I think it was in Saskatoon. And after the lecture, most of the time they were done in the evening. So after the lecture, people were filtering out, but there was maybe a dozen people that kind of hung around. And I said, well, pull up a chair if you want. We can just sit here and chat. I'd fly out in the morning, but I haven't got anything to do tonight. So if you want to talk, let's do that. So they sat down, they had lots of questions, and they were telling me their histories. I'm going to myself, God, that sounds like me. So I get home and I'm supposed to have my gallbladder out. So I run into Redwine and I said, say, I'm going to have my gallbladder out next week. Would you mind stopping by the OR, taking a look?
Just in all your spare time.
He said, did you have endometriosis? And I said, yeah, I did. He said, well, it doesn't work like that. You have to come into the office for a consult. I said, oh, can we get this done before my surgery next week? And he said, yeah, come on in. And so it took him 3 hours to remove the rest of the endometriosis in my pelvis, and 45 minutes for the other guy to do the gallbladder. I woke up in the recovery room pain-free. Now, by that time, I'd had white hot sciatica, continuous, for 26 years, 22 of which were after my curative hysterectomy. And so he's sitting at a desk kind of at the end of my bed in the recovery room, and I yelled at him. I said, say, what did you do in the OR? He said, why? I said, because my leg does not hurt. I do not have any leg pain. My foot is not on fire. My back doesn't hurt. What happened? And basically, I had pretty substantial endometriosis that was left on the uterosacral ligaments, where it was pretty invasive, on the pelvic sidewall, on the pelvic floor. I had bladder and bowel pain, but no bladder and bowel involvement, which I didn't even suspect endometriosis till the patients in Canada taught me, So that was pretty eye-opening for me, and I think it was eye-opening for him too. It was really the first case of sciatica that he had encountered. But it was pretty clear it was related either to the irritation of the nerves or maybe the involvement of the ligaments. But prior to that, I kind of jumped ahead there right after I got the hospital to give me some money so I could travel.
In itself.
Yeah, I called a magazine in Northern California called Medical Self-Care. And it was kind of a small little journal that was run by a physician, and it's no longer in publication, but at that time they had about a 60,000 circulation. And I said to him, I think this guy's onto something really important, kind of fits the kind of things that you look for, or which are kind of off the mainstream, but kind of effective. So he sent a reporter and a photographer up, and they did a story. The writer and I did an article called Endometriosis Reconsidered. And they did a nice, I think, 3 or 4 page spread in their magazine. It was really well done. The thing I didn't anticipate was the week the magazine hit the street, we had 1,000 phone calls. Wow. I virtually shut down our switchboard. And so I went, whoa, there's something going on here. And so then I began the education process. And that's really what started the whole thing in terms of patients coming to Bend. And as his work got published, then very quickly he was teaching surgery all around the world. He was teaching the people in France and Germany and Russia, and I think he taught everywhere but Antarctica the basic recognition issues. He said there wasn't a lot of endo down there.
No, probably not. I don't think a lot of people want to go there.
But I think
Exactly.
people would for
But
endo.
he was teaching the basic. He was teaching the basic issues of what does it look like, what does it really look like,
Mhm.
and how does that change over time, and where is it found, and how do you get it all out of there?
Mhm.
And as he began to teach those basic premise, people began adopting it, and they would have him come and either help in surgery or demonstrate surgery or whatever. So what's really happened over the last 30 years is anybody that's doing effective endometriosis surgery is kind of glommed onto that early work of his.
Mhm.
Prior to that, a physician named Ted Wheeler, and I think, I'm not, Jim Wheeler, I think, and Russ Malinak had been doing some excision without the full understanding of Redwine's research because it was before his work was published. And they were getting recurrence rates of around 50%, which was better than the standard at the time. Yeah.
Right.
And so then what began to happen is when Redwine picked up on that, then he began to biopsy everything that was in the pelvis that didn't look like normal endometrium. And so very quickly he was teaching himself it wasn't black disease on the ovary, which was kind of the standard at the time.
Mm-hmm.
So as that began to spread, more and more people began to adopt it. So that was kind of how he got into it. His first wife had endometriosis, and she really taught him everything he needed to know about the disease. He was very, very generous about his recognition of her contributions.
Yeah.
And then when I approached him, of course, I worked for the hospital. He was an independent practitioner. So we did this kind of joint venture going together with the idea that we would establish the first laparoscopic excision program. It turned out to be in the world. We didn't know that at that time, but that was committed to the complete excision of endometriosis. Since that time, a lot of new things have kind of come in. You know, it's more common to find endometriosis causing sciatica. It's more common to find endometriosis affecting the diaphragm. It's more common to see kidneys at risk. People are more aware of that now. I think 2 years ago, I did a survey in Nook, and we found, right away, 18 people that had lost kidneys, 2 people that had lost both kidneys, and were on dialysis awaiting transplantation. So, I think it's kind of, as people begin to look, the learning has grown, both physician and a patient,
Right.
I get a lot of criticism for teaching patients so much information, but
I think it's
I
great.
think it's saving some lives.
It is.
It's making a
Really.
difference. Yeah.
Yep.
Absolutely.
3 of us right here, it for sure did for us.
Yeah. Do you feel like endometriosis is more prevalent now, or is it just that we're finding or more aware of it now?
I think that the patients, Dr. Vidali from New York City, I think he operates in New Jersey, but he lives in New York City, said a couple of years ago, he said, we've changed this whole thing because of the patients, that we now have the sort of information-driven patient education where patients have more information than physicians. So I think part of it is patients know and they demand, and they'll go someplace else if they don't get what they need. So that's part of it. I think the endometriosis awareness efforts, the Worldwide March, all of those things have helped. I think it's awareness. I don't think there's more of it, but I easily could be wrong. I don't know. It's and I always worry because my view is biased. I'm working with 170,000 patients and their histories, and there might be a whole nother world out there I don't know about. Clear back when we first started the program, 1986 or whenever it was, I began surveying patients. Kate Weinstein had a book out at that time on endometriosis, and I've forgotten the title of it. I'm sorry, Kate, but I did. But she had been doing surveys on patients as she interviewed them and found that 75% of the patients that she talked to had been dismissed as neurotic. And I thought that was a really important factor. So I began doing just basically a tick sheet survey of every patient that came to us, and my figures matched hers exactly, 75%. The
Yep.
difference for us was on every one of those patients, we had a biopsy proven report that they did have endometriosis, even though
Right.
they'd been
Right.
dismissed. Yeah.
The science
So
behind it.
I don't think it's more prevalent, but I could be wrong. I do think we're doing a better job in educating patients to stick with it when they're in pain and have symptoms, and that we're starting to see growth in the physician
Yep.
area about the importance of listening to patients. I
Mhm.
just got an email this morning and posted it in Nook from a physician who is starting a big program for the African continent, that there's
Mhm.
so many people there have no access to care. And I
Yeah.
was so excited to see that. I really, because I feel so badly, we hear from those people and there's nothing we can offer them. There's only a few specialists there, and most of them want patients on referral, and patients can't get
Mhm.
referrals,
Yeah.
so it's really a frustrating place to have the disease.
I think
I,
that's
I
true. I
think
think
I
the
think we're
disease is
seeing
frustrating.
yeah, I think we're seeing physicians jumping into this saying, you know what, we haven't done a good job.
Mm-hmm. I would
The
agree with that.
movie the movie that Shannon Cohen has, the documentary, which will be shown on public broadcasting the 29th of March on all 300 stations in prime time, called Below the Belt. In
Mm-hmm.
her preparation for that movie, she did a survey. I think she was the author of it, and found that about 80% of gynecologists don't know the symptoms of the disease. This
Nope.
is stunning when you look at almost 200 million women worldwide, and the gynecologists are the primary caregivers for this
Right.
disease. If 80% don't know the symptoms, well, no wonder we're in trouble.
Well, and correct me if I'm wrong. I might be wrong, but I'm pretty sure a lot of the research and everything done that is getting handed to these gynecologists in school and post school in like credentials and things like that is done really from a pharmaceutical standpoint and from the company who pays for all of this. Am I incorrect in that, or am I correct in that?
Yes, and the British Medical Journal here a couple of years ago called out the amount of conflict of interest in the publications. Not
Mm-hmm.
only is the research sponsored by the big pharma, but then the papers are written by people who are beholden to big pharma, and big pharma is editing those papers. This is a really important observation that you have. Um, and for people to get a good quality study on excision takes money. But in
Mm-hmm.
addition to that, every time they try to do one, they do not control for the surgeon's
Right.
ability to recognize and find and remove disease.
Mm-hmm.
So they'll come out with, well, medication and excision are about the same. No, 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 no. They're
No,
really not.
no.
Yeah.
And we've all experienced that, I think, personally. And then Shelby and I, having a good surgeon is really what will, is not, is not foolproof as far as curing endometriosis, because obviously there's reoccurrence and things like that. But it is key to living a fuller life because
It's absolutely key to the return of the quality of life. There's no question
absolutely.
about that. The other piece, though, that's come in along recently has been a better understanding, and I thank
Mm-hmm.
Sally Sorrell for a lot of this, getting that word out, is the pelvic, well,
Yeah.
backing up to acknowledging and identifying all of the pelvic pain generators. So excision is step one, really. You remove disease, and then, okay, the patient says, well, I still have pain. So you come back and look at, did we get all the disease? Then
Right.
you look at, what's the uterus like? What are the ovaries like? What's the pelvic floor like?
Right.
What other issues are going on in terms of perhaps interstitial cystitis or irritable bowel or any number of things? The the double-edged sword about irritable bowel is most patients have some irritable bowel with endometriosis,
Yeah. 100%.
and yeah, it's important. Yeah.
And the funny thing about that is I don't think it's just because of the endometriosis. I think it also is because of our lifestyles oftentimes, but then endometriosis compounds it. So it adds to that even more. And I think
Sure.
that's why, we've talked about before, follow-up post-excision surgery is key as well, because, and like Sally has mentioned before, our bodies are not used to functioning as whole bodies. We are used to functioning as
Exactly.
endo bodies.
Yeah,
And
exactly.
so Shelby and I have experienced this with working out, for instance. So we've realized that we both compensate for where our pain was because our muscle atrophy is there.
Yeah. Yeah.
And it's
Yeah. We adapt to,
absolutely.
back, if you look at the quality of pain, we're talking about a term that I coined some years ago, peritoneal quality pain. The symptoms that patients have mimic peritonitis, which is something that every nursing student and medical student on the planet learned about.
Right.
You can't ignore those kinds of symptoms
Mm-mm.
unless the patient has endometriosis. Then we kind of go, oh, it's just a period. But, you look at bloating, you look at intense pelvic pain, you look at nausea, vomiting, bowel dysfunction, bladder dysfunction, anxiety, pacing, just the pain is so severe that it creates all kinds of issues for us. I think there were two things that impressed me about this. One, there's a professor of gynecology now retired from the United Kingdom named Shirley Pierce. And she wrote a chapter in a book called Gynecology and Psychological Problems. She wrote a chapter 6 on chronic pelvic pain. What she discovered was most patients with chronic pelvic pain, not specifically endometriosis, but pelvic pain, had abnormal personality profiles as studied by the MMPI, or Minnesota Multiphasic Personality Index. Okay. But what nobody looked at until she got into it was, so what are they like when the pelvic pain's gone? Their personality indexes returned to normal in almost all, even the most severe got much better. So we're talking about psychosis and neurosis and depression and schizophrenia, and all of these issues that cropped up abnormal got better or much better or disappeared. And then about 2017, there was a big study that came out of China looking at central sensitization. The problem I have with central sensitization is we attribute the patient's pain to that without ever resolving their disease.
That's big.
And what the study in China showed us was that you resolve the disease, resolve the pain, and central sensitization starts getting better and actually improves.
Right.
So the thing that really worries me about the whole mental health piece of this is that we'll say, well, she's in chronic pain. Well, she's got central sensitization. Well, she still has endometriosis. Let's fix that first.
Yeah. Yeah, absolutely.
Really. Yeah, really. And so it's so important to be sure what you're dealing with, because if you just say it's mental health or it's central sensitization, the patient gets dismissed while they're still dealing with an invasive disease in their pelvis. So we need to get first things first. Let's get their disease cleared up. Let's get their other pelvic pain generators under control. And then if they need help with more mental health or more central sensitization, that's fine. But let's not try to blame those issues instead of acknowledging they have disease that needs treating. That's kind of been a favorite thing that bugs me.
It is. And I think there's a double-edged sword there in a way, because we've talked about this before, but because we have dealt with this pain all the time, sometimes I remember after Shelby's excision surgery and she was explaining some of her pain, all of a sudden I'm starting to feel my pain. I was sitting there telling my husband, I'm like, oh no, what's happening to me? Because I'm feeling this, And I said, but there's an element to it, right? If we don't deal with the trauma of what our pain did to us, then I think that it's really easy to go back to that pain place, because sometimes it can be a mental struggle because there's fear there.
There's fear a lot. You hit it right. There's a lot of fear that, did this surgery work? Am I ever going to get away from this? Oops, I've got something coming happening again, that you're
Mm-hmm.
afraid you're going to go back to where you were at one time, so that's one of the things that we try to encourage people to remember, that excision is step one. There can be
Right.
multiple other factors, including mental health, involved in the ongoing pain.
Mhm.
You make a very good point there. The other piece, when you were talking about your bodies a minute ago, one of the things that I've noticed with people who have bowel disease is it takes the bowel time to learn. It doesn't have to be painful. It doesn't have to be crampy. It doesn't have to
Yep.
make you panic. Where's the next John?
Mhm.
That what I've seen in a lot of people with significant bowel diseases, they're looking at 3 to 4 to sometimes 6 months of continued improvement.
Mm-hmm.
So that what you have at 2 months is, well, is this the best it's going to be? No, give it a little more time.
Yep.
Mhm.
And I've had a number of patients give us feedback to say, it took me 6 months before my bowel just kind of quit being in my brain all the time, because it suddenly was working normally.
Mm-hmm.
So
Yeah.
you make very good points about the body and how we've accommodated, and sometimes we have to teach the body to be a little different,
Mm-hmm. Yeah.
go back to normal. What is normal?
What is normal? I feel like we struggle with finding our new normal after excision, especially after hysterectomy. If it's a total hysterectomy, I feel like it is really hard to put yourself into what is normal and knowing what is normal and what isn't normal. I struggled with that a lot after my hysterectomy because my normal is so different now, you know?
It's a place you've never been before.
Right.
Mhm.
And so now you've got all this new learning. I equate that with loss. When somebody loses someone in their family, for instance, someone they love dearly, they keep waiting for things to come back to normal, and it takes some time to discover that normal's something different. It's a
Mm-hmm.
new normal.
Yep.
Might not be what we want, but it's a new normal. Things are never going to go back the way they were.
Right.
And I remember I lost a brother. He was
Yep.
20 years old in the Vietnam War. And I kept waiting. I'd been kind of the primary caregiver of him from the time he was a little baby. And so it was as much like my own child as anything.
Mhm.
I kept waiting for things to go back to normal. And it took me probably 6 or 8 months to realize, you know what? You're never going to feel like that again.
Yep.
Mhm.
Never
You
gonna feel
know,
the same. Mm-hmm.
I think the losses that you have physically, emotionally, I
Yep.
think the other thing that you've touched on about things being different is the impact of having your disease denied,
Mm-hmm.
the
Mhm.
impact of the gaslighting, the impact of, I cannot believe some of the stories about how rudely patients have been treated.
Mhm.
I
Mind
mean,
blowing.
go ahead.
It's just mind blowing.
Yeah, it is. And
Mhm.
somebody said the other day about uh, having their own experience denied as they try to explain it. Wait a minute, I'm living in this body. I kind of know what it feels like, and I know what it used to feel like, and we're not there anymore. To
Right.
have that denied, and rudely denied, is
Right.
really harmful. It's harmful to people.
Yep,
Yep.
it is. And I think Chelsea was talking about that in our last recording about just how harmful it was to have her being denied constantly for pains that didn't necessarily equate to her uterus, like, and that's the thing and I remember telling Shelby after her hysterectomy, now we kind of go through a grieving process. Do you remember me
Yeah.
talking about that?
Yep.
I went through this grieving process. And part of that process was the time we spent trying to figure out this disease, the time we spent away from our families, just trying to survive the day in, the day out, the time we spent rejecting relationships because we didn't have the energy or the time to give to them. Now we're in this place where we feel physically much better, but we need to give ourselves the space to grieve
Mhm.
because it's so important to acknowledge what you've been through to move forward.
Mhm.
Absolutely, you're absolutely right. And the thing of it is that over the years that you were in all that pain leading up to finally finding whatever care it was you needed,
Mm-hmm.
A lot of relationships got damaged because, you make an agreement that I'm going to help sponsor, say, a dinner or a celebration, or I'm going to meet you for lunch, and the last minute you bail out because you feel like hell. And everybody goes, what's this? You bailed out. I mean, we were all expecting, to be able to do this. There's no real understanding of what made you make that decision. People
Right.
don't really understand what it's like living on the couch with a heating pad half your life.
Right.
It's
Yeah.
really something people can't relate to.
Right.
And just the pain is, so different than anything else. Someone just posted, that endometriosis cramps and pains are equated to be much more intense than childbirth. And I could completely agree with that.
Mm-hmm.
It's just,
Yeah, you go back to the terminology I use of peritoneal quality pain. Peritonitis is one of the most painful events that a person can undergo. It's very similar to labor in that the whole abdominal cavity gets acutely inflamed, acutely bloated. You're just in agony.
Right.
And we dismiss it so easily. It gets dismissed so easily. And patients have nowhere to turn. It's like, wait a minute, I can't even get off the couch. And you're telling me that there's nothing wrong,
Right.
That whole gaslighting thing is so damaging to patients. It's one of my really frustrating aspects of all this. If we could just be a little nicer and say, you know what, I don't know what's the matter with you. Maybe I should try to find another doctor for you.
Right.
Right.
Yeah. And that's one thing we've talked about is, we wish more people in the healthcare industry would kind of pass the buck. Like, I can't help you. Let me find somebody who can, because clearly something's going on. And if we're not fixing it, let me help someone. Let's find somebody else. And, unfortunately, I feel like that's may take a long time to get to that place, just maybe because of ego or who knows what else. But, it would help so many others if, people could just, hey, I see you, I hear you, but I can't help you. And I had a physical therapist do that to me, and it sucked, but I moved on from him and found somebody else and who actually helped me a ton. So, if it wasn't for him saying, I can't help you anymore, you're doing great, but I'm not sure what else I can do for you, I would have never, been where I am today without him telling me, I'm sorry, I can't help you.
Well, it's humiliating maybe, or humbling in some way, for them to have to do that, but it's also very honest. And you look at what happened for you. You said, oh, okay, he can't help me anymore, I'm going to have to move on.
Right.
And I think that's one of the things in Nook that I say over and over to people. It may be time for another opinion. Patients are so supportive of their gynecologist, even sometimes when the gynecologist isn't particularly supportive of the patient. They don't want to leave. They feel a loyalty. It's one of the frustrations for patients is that they'll recommend a gynecologist to me for Nook, and then I'll go, well, what's the key factor here? Well, he's so nice, or she's so nice. Well, okay, then I look at their training. There isn't any training, for MIGs or for additional understanding of endometriosis, but it's that they're nice and they want to recommend them for that. That's not quite enough. I mean, it's wonderful that they're nice and supportive, but it's not quite enough to get the patient where they need to be in terms of restoring their quality of life.
Right. I felt that way. We talked about this in one of the other podcasts, that I loved my OBGYN, and she was the one that had discovered, and really early on in the journey for the most part, that I had endo and had enough knowledge to kind of walk me through that. But she didn't have enough knowledge to really treat it effectively. And I think that is maybe the biggest differentiating factor there. Is it's great if you can get the diagnosis, but then what are they going to do with that diagnosis? Are they going to be able to, treat that effectively?
You touch on 2 points there with your comment. First of all, almost all gynecologists who come out of their residencies are not prepared to treat endometriosis effectively. It's back to the big pharma doing all the publishing. So they're not really prepared. They don't have a clear understanding of the disease, its symptoms, what it looks like, how that changes, where it's found, how you take care of it.
Right.
And so that's really important understanding, as we go forward.
Mm-hmm.
Secondly, even if they've completed a fellowship, a minimally invasive gynecological surgery fellowship called MIGS, not all MIGS programs have a key endometriosis component. So you can learn to do minimally invasive surgery, but if you don't understand the key factors around endometriosis itself, you haven't gained a hand in helping patients with endometriosis.
Right.
You can take their uterus out, you can take their ovaries out, you can, do a diagnostic exam, whatever. The other piece of that is the diagnostic exams, which are frequently done with a single scope in the abdomen, and they'll come back with a report. Your uterus, tubes, and ovaries are pristine. You do not have endometriosis. The important finding about that is the uterus, tubes, and ovaries are not the most common sites of involvement. They are actually 7th and 9th in order of frequency. So if we're just doing a single scope, we're looking at the uterus, tubes, and ovaries, everything's are fine. It's really common for us to have patients that have invasive disease of the lower pelvis. It takes more than one scope. Those organs, uterus, tubes, and ovaries, have to be moved out of the way in order to visualize the ligaments, the bowel, the ureters, the pelvic floor. And those are the areas where the disease is most commonly found. So that's a pretty important tool, the diagnostic laparoscopy. Patients need to understand that a single scope isn't it.
Right. Well, thank you so much, and we appreciate it. And we're going to have you back on because
Anytime I can help, I'm here.
you're great.